All right, we'll go on ahead and get started. I'm sure there's some other people that will probably join us shortly, but I want to be conscious of everyone's time this afternoon. So, welcome. If you are not aware of who I am, I'm Shelby Dry. I'm the archives coordinator here at Mercy Archives, and I am responsible for putting on our Mercy Archives speaker series, which is why you are all joining us today. So, before we jump into the presentation, I like to always kind of just give some general housekeeping reminders as well as kind of tell you about what's coming up for Mercy Archives as well. So we will have time for questions at the end. If you do have a question as we're presenting, feel free to type it in the chat and we will get to those at the end of Sister's presentation. This will be recorded and it is being recorded right now. So it will be available on our YouTube channel afterwards. And that will be available on all of our social channels as well. So YouTube, Facebook, and Instagram. I'll make sure to make a post on there so it is easily accessible to everybody. If you don't follow us on our socials, it is at Mercy Archives for both Facebook and Instagram, as well as our YouTube channel. And one last thing before we get started, just to let everyone know, we'll have a little bit of a hiatus with our speaker series in June, and we will pick back up in July on July 8th, and we'll have a presentation on the Mercy Focus in Haiti. So that one should be really good. And more information, once again, will be shared on our social channels leading up to that. But for today, we are here with Sister Patricia Talone, and I thank her for her time this afternoon. I will let her do the introductions on her presentation, but I just want to say welcome and thank you for being here.
Thank you very much, Shelby. It's a pleasure to be here, and I very much look forward to the comments and questions from the participants. What I'm talking about today, the title that I gave this is Healthcare Ethics: Living the Spiritual Works of Mercy. But it's important that those of you who don't know me know that I have been a Sister of Mercy for over 60 years. And during that period of time, for the longest amount of time, a little bit over 40 years, I have functioned in different capacities as a healthcare ethicist. Some people today, they use the term bioethicist. I prefer healthcare ethics, and you'll see why at the end of the presentation. And I have considered, as I've reflected on my call to do this type of work, I have really seen it as an expression of the spiritual works of mercy. Next. Just to give you a context, these are some logos of Mercy healthcare organizations throughout the United States. And I am aware that our healthcare organizations are not only within the United States, we have various services in other parts of the world as well. But just for you to know or understand that if the Sisters of Mercy healthcare ministries had all at one point been folded into one system, which was really not done so much in the middle of the 20th century. But if we had been in one system, we would have been the largest system in the United States. We have the logos that I have up here, just in case any of you are from these places. To the top row left is the Sisters of Mercy logo from St. Louis. The next one is the Baltimore Mercy Medical Center, which is a very large urban hospital, and other ancillary. I won't go into all the details on these. The Northern Light Mercy Hospital is actually the Portland, Oregon hospital that has joined with another Northern health system, local health system there, but retained its Catholic identity. Mercy Cedar Rapids is, again, it's more than just a hospital. It's a small system in that area. The top right-hand logo is Catholic Health Initiatives, which is frankly the largest not-for-profit health system in the country. And in that are several Mercy groups from Chicago, from Omaha, Auburn, Burlingame. I may not even have gotten them all, but it's very, very large. Bottom left is Trinity Health, and that is again a very a large system in the United States, and that includes the Mercy systems on the East Coast, what used to be called Catholic Health East, as well as Detroit and well, Detroit for sure. I don't want to get ahead of myself. The green box there is St. Joseph's in Candler, St. Joseph's Candler, which is in Savannah, and that's a joint venture between the Mercy Health System in Savannah and Candler Health, which was another faith-based not-for-profit. The one little tiny one on the bottom, Scripps, is Scripps Mercy is part of the Scripps Health Network in San Diego or Southern California. Really, it's larger than just San Diego. And then Bon Secours Mercy Health is a joint venture between Mercy Health of Cincinnati and the Bon Secours system on the East Coast. And that's also a very large and active system. So the reason I wanted you to see these is even my movement into from teaching, which I had done for 20 years, into healthcare ministry or into particularly healthcare ethics was within the context of the Sisters of Mercy commitment to the poor and the sick, as well as the ignorant. We can talk about all three. Next. As you know, or many of you know, the Sisters of Mercy take a fourth vow of service to the poor, the sick, and the ignorant. And like all other Christians, we commit ourselves to the spiritual and corporal works of mercy. But as I reflected on what I have done as a healthcare ethicist, I thought, all right, which one of these works of mercy? I mean, I'm not a clinician, I'm not a nurse, although I have always been interested in healthcare from the time I was really a pretty young sister. But I really see the spiritual works of mercy being carried out in my ministry through the notion of counseling the doubtful. And that's everybody from a patient to the physicians to the administrators. Comforting the sorrowful, which is particularly when I'm working with family members and sometimes even staff who experience sadness and loss at the death of a patient, and then praying for the living and the dead. And I can't tell you how many times, I mean, really, every time that I have come to a patient consult, particularly, or patient care consult, I know that we would spend time in the beginning praying, but it was really something that I would keep within the context of my own prayer until whatever resolution came about in that particular case. Next. I've been interested in this field off and on, and I don't want to get into too much history or too much autobiography, but early on in my religious life, I taught high school religion. I had worked toward a master's in theological ethics and taught religion in high schools. And this is during the early 70s when we were in the midst of the war in Vietnam. We were certainly in the midst of the sexual revolution, and in the school in which two schools, which I taught at that time, I would say there certainly challenges of drug abuse and even alcohol abuse were very evident. And so when I was getting my master's, I was really interested in theological ethics because of those reasons. Within the Catholic tradition, Catholic healthcare ethics emerged first from what I would call pastoral theology. That is, how does our faith become expressed or lived out in the realities of every day? And I mean, as you know, parents and all kinds of, it's not just healthcare workers that are faced with medical challenges, but it's parents, it's families, Do we need to move to a place that is more healthy for one of the partners or the children? There are many, many pastoral questions that arise. And really, if you go back in the Catholic tradition, that were being addressed early on in the 1500s, 1600s. So this is not something new. However, I would say during my lifetime, from the mid 1950s on, um, this was accelerated by modern advances in medicine. Now, the first modern advance that really, I think, um, impacted, I would say, the biggest advancement in the last century was the development of antibiotics. Because prior to that, people died from infections, they died from pneumonia, and all of a sudden, and this was, antibiotics were discovered. Penicillin was discovered in the 30s, but began to be used during the war, and then much more so later. So those advances, antibiotics, ventilators, the ability to do CPR, and then later tube feeding, all of those things really brought about a focus on medical ethics. Another thing that really influenced me very much were certain key cases. And I have a slide coming after this to show you some of those cases. But very early on, when I was still an undergrad, there was a case here in Philadelphia of conjoined twins that needed to be separated. And C. Everett Koop, who was later the Surgeon General of the US, he was a surgeon at Children's Hospital in Philadelphia and chose to not just to let these conjoined twins die, but they recognized if they remain conjoined, neither one would live. But if they separated them, it was possible that one would live. And that was an agonizing decision for the parents, for the doctors, and it got a lot of attention and press, and it really captured my imagination. Even though, as I said, I was an undergrad and I didn't even know this field existed. Gradually, and I would say this was in the 50s, 60s, and then finally into early 70s, healthcare ethics developed as its own branch of learning. But the important thing to note is that as it developed into a branch of learning, it was interdisciplinary. It wasn't philosophers and theologians only, but it was doctors, it was attorneys, it was healthcare administrators who were interested and wanted to pursue this type of learning. Next. Now, I already talked about the origins of the field and probably talked about a lot of what I have on this. Certainly, the contemporary advances, antibiotics, the advances in reproductive medicine. Even when I began in this field in the 80s, it was if a baby was born prior to 25 weeks, often the family would just decide we're going to let this child die. Now, because of the advances in neonatal intensive care, there are children born as early as 21 weeks, which is very early, who not only are able to live, but who thrive into adulthood. So there are advances in reproductive medicine. And then the other thing in reproductive medicine, and this is in the news still all the time, are medical advances to try to help couples who experience infertility. And anybody have questions on those, I can talk about them, but I don't want to spend a lot of time on that. Well, I mentioned ventilators and CPR and the key legal cases, but another thing that has really come about very much in the past 20 years is the advancement of genetics. And so there were certain diseases that we thought were genetically linked. Now we know they are because it can be tested. And the thing that is I'll give you one for instance. If an individual is diagnosed with carrying, I'm trying to think of the name of the disease, but carrying a certain, the name escapes me, but it's something um, in Latin America, particularly in Colombia, and where an individual is born with a genetic difference that makes them very, very short in stature. And there are other physical attributes. You may have seen people that would fit this description, but we have learned that if we go in and do genetic intervention, which is called CRISPR, if we apply that and remove that defective gene or different gene, I don't even want to call it defective, that those persons also have a built-in immunity to cancer. So if we remove the gene, they lose that immunity. So there are many, with genetic interventions, there are benefits, but there are certainly side effects or burdens, and many of them we don't even know yet. And then the last thing that I have up here, and those of you that read Catholic literature know that Pope Leo is very much interested in what are the effects of artificial intelligence. And we know that artificial intelligence is already being used in medicine, in many cases to the advantage of the patients and the docs. But there are also studies being done to show, does artificial intelligence diagnose in a way that is different from a physician who is right there and sees and can apprehend, let's say, the patient in a different way. So all of these advances really developed or moved us toward the origin of the field. Next, please. These are just some illustrations, and some of these may be familiar to you. Again, on the top left is an image of conjoined twins. I didn't want to put a photograph in there. Then certainly advances and challenges in medicine, medical advancement, and as I said, particularly all the different types of antibiotics that can be used. The next picture is a picture of Terry Schiavo, and she was a woman in Florida who died after, I mean, there were court cases, but the removal of nutrition and hydration, because her husband requested this because she was in a persistent vegetative state. The next one on the far right, is actually an older case than Terry Schiavo's. That is a photograph of Karen Ann Quinlan, who, and actually her case first came to light. I can't believe it. It's 50 years ago. Again, this is when I was doing work and finishing after my master's. And her case was, again, the removal of treatment, but in this situation, it was the removal of the ventilator. The next are ventilator and ICU advances. Again, we can keep people living for longer, but one of the questions is what is this going to do to the patient? What is the patient going to need after this? And then the last one on the right, which is an image of a fetus, is looking at the advances in reproductive technology. Next. This is an image, if you know the scripture story of all of them, many of Jesus' healings, but this is one of the ones that I happen to love the best, I guess, because I think it's foundational to us, and that is that Jesus' certain desire to heal, but in the case of the man who was unable to walk, his friends carried him on a pallet to where Jesus was meeting and lowered him in through the roof. And the interesting thing, I see this as if you will, almost a paradigm of Catholic healthcare, because healing can and does take place. And we know that God has the power to heal, but it is done, particularly in Catholic healthcare, with the help and support of a whole community. And so we speak in Catholic, not just Catholic healthcare, but Catholic terminology of the fact that our dignity comes about within the context of community. And it is because of this that within Catholic healthcare, we have ethics committees, ethics consultation groups, institutional review boards, all different ways of trying to um, assist in the very difficult decisions that patients and families have to make. Next, please. I already mentioned to you that this role is interdisciplinary. And so even in my own life, when I first realized this strongly when I was working on my dissertation, because I did my dissertation on theological implications about tube feeding. But in order to do my research, I went to Marquette University. I had to use the Arts and Sciences Library, the Arts Library, pardon me, first, then the Science Library, and then the Law Library, because all of them addressed the issue that I was trying to talk to. So in these pictures on the top is an administrator, then a patient in the bed, then at the bottom you see a nurse taking care of the patient, and the next one is a family gathered at the patient's side, and then on the right is a physician. So really, in my practice, I dealt with all of those groups of people. Although I would say to you, probably I primarily dealt with the doctors and nurses, and then as needed with cases, would deal sometimes, although not often, with the patient, but more with the patient's families or people who were making surrogate decisions. Next. So here are some of the contemporary clinical issues that I've had to address during my practice. I will say to you, and I think this is still true in clinical or hospital settings, that most of what I dealt with really was end of life issues. Although in the Mercy system in St. Louis, because that they have a very, very large service of OBGYN, I also dealt with reproductive issues. I dealt with transplants, actually, because thank God the government has provided us with the opportunity to offer our organs. This was not something that was problematic, but often needed some instruction with either staff or with families in that regard. Another big thing that I'm going to begin sort of to go clockwise. Many times I had to deal with the ethnic, cultural, and religious diversity of the patients. So different, just one example, two, well, this happened to me more than once, but I can remember an early case with a patient who was Jehovah's Witness and who was brought to the emergency room, and she was really bleeding to death. And she was conscious enough at the beginning when she got there to say, absolutely no, I don't want any blood products, period. And the hospital, it was a teaching hospital, so we had residents and interns who were panicked. They called her husband, and he said, this really is central to who she is. I will not go against this. So sadly, this woman, who was only in her late 20s, died. And however, the doctors knew that they could not force treatment on her that extended beyond her religious commitment or thinking. The next one, artificial intelligence, I just talked to a little bit, and we will talk more about that. And then the last one that I have on the bottom left-hand side, access to healthcare, I think is really, really important for us to look at or think about, so that I have seen my role not simply as a clinical ethicist, but needing to ask the questions sometimes at an administrative level about access to healthcare. How are the poor served in this context? Because not as a Christian and also as a sister of mercy, this is part of my commitment. And I want to just mention, I hope all of you have wonderful health care and wonderful ability to get the health care. Our country, most would probably consider our country the most advanced medical society in the world. However, and I don't know how many, if you would be aware of this, but as far as infant mortality rate, which is a key indicator of healthcare, we rank 29th in the world, which is unheard of. And you think, why could this happen? Well, it happens because in many cases, people who are poor don't have proper access to health care. They can't get the normal preventive care that's needed, and the mothers do not get adequate prenatal care. And we also have among minorities, for example, among African American women, a very high rate of maternal death, much more disproportionate and higher than in many other poorer countries. So, this notion of access to healthcare is really vital, I think, for us. Next. In addition to clinical issues, and this is one of the reasons why I prefer to call what I have done healthcare ethics rather than just bioethics, um, is that over the years, I have come to realize more and more that there are organizational ethics challenges that we faced that weren't, at least in the beginning textbooks that I studied when I was getting my degree. One of the biggest areas is issues of human resources. Um, Nursing staffing. If we have too tight a nursing staff, are the nurses put under undue pressure? Are the patients threatened? Another area is business partnerships. And I'm not talking here only about Catholic and other than Catholic organizations, although that's part of it, and the bishops write about that in their document on healthcare. But I'm talking even about partnerships with an organization that shares a very different culture or very different values. And often those differences are harder to solve than are the religious ones. Another area is mergers and acquisitions, which seems to happen all the time. What both systems either purchasing or acquiring other healthcare organizations or even getting rid of them. And I think sometimes it is what is ignored is the impact not just on the patient's lives, but on in the society and that community, the geographic community. Another is opening and closing lines of service. Um, for example, one of the hospitals that I worked for was, I would call it semi-rural rather than rural, but it was pretty far, a distance from the city. And they had a small mental health unit, I think, of 9 or 10 beds, which is not a whole lot. And usually, what would happen would be if a patient showed serious signs of mental health, they'd be brought to the hospital. They would be in that unit, and then they would have their medications. They had visiting psychiatrists that would come to the hospital, but they would have their medications stabilized so before they could go to the hospital in the city. But this hospital also served some young people, teens, um, and many of them from rural areas who were experiencing a tremendous amount of mental illness. Now, if when that hospital, they realized they were losing lots of money on that unit and had to try to decide what to do. How do we serve the community and yet give patients the best care that they could have? So that ultimately what they did was still retain a couple of beds to bring people in and get them stabilized. They set up, this was at the beginning of telemedicine, they set up a marvelous room or area where the patient could be interviewed by the doctor in the psychiatric hospital, and then eventually, after medically stabilizing them, they were able to move them to the other place. And the last point that I have there is the real commitment to the poor and underserved that I really believe needs to be part and parcel of who we are as Catholic healthcare, but also who we are as Mercy. And we can talk about some of the, some practical applications of that, but I don't want to spend a whole lot of time on that now. Now, Shelby, that if you come to the next one, really this, I'm sorry. The next one, and then we're almost finished. In sort of in summary, as Shelby and I talked about my presenting this, it was a good opportunity for me to kind of look back over the many years that I've spent in this. And I am truly grateful that I have been able to serve in this way. And I consider my entire vocational career, I mean, including teaching in elementary and secondary school and at a university level, and particularly the healthcare ethics piece, as a real blessing and a privilege. First of all, it's provided me that opportunity to live out in a way that has been hopefully congruent with my gifts and beliefs, to be able to live out mercy. I have recognized over the years that I've been able to assist people sometimes at their most vulnerable, and that includes patients, probably even more so families, and as well as physicians, nurses, and administrators. And the other thing that I've realized over the years, I still, even though I am officially retired, although I still do some consulting, I still spend about an hour and a half each day trying to read professional literature, because this is a field that requires continued learning and is always a challenge. And I really believe that anything that is a deep challenge is also an opportunity and a call to growth and to service. So next, so with that, and I told Shelby I would really only take a half hour because I wanted to have time for either, and it does not have to be questions. It can be comments, it can be whatever. And if you ask me something I don't know, I'll say that. But I mean, I would be happy to discuss anything with you that I've covered today.
Sister, my name is Nancy Piness, and I'm a Mercy Associate from Washington, D.C. and New Jersey. Mercy for high school, Jesuits at Georgetown, and they allowed me to color outside the lines. And 47 years ago, when I graduated, I studied medical ethics and end of life, worked at the Kennedy Institute, and am now just a rabble rouser in aging issues. But I saw you had also been at the Kennedy Institute at one point, maybe
Yes. And
um,
do you still live in DC?
50 years in DC. Yes.
Let me ask you this question. Is the Kennedy Institute of the library is still active and
It's
functioning?
still very, very active. It's located on the first floor of the Healy building now.
I
It's
know. Oh, okay.
no
I
longer in the car barn.
All right. Well, the reason that I even that I went there as a visiting fellow, I think it was called. I forget her. It was during my sabbatical year. This is a long time ago. But the reason I wanted to, I mean, obviously, Georgetown, the Kennedy Institute of Ethics is outstanding. It had a very strong ethics committee that was really a model for many other. And Dr. Ed Pellegrino was teaching there at that time. But that library, that ethics library, was the best library in the country. And it was such a thrill for me to be able to go during that semester and spend time there.
it's remarkable, and it was more anecdotal. This was so touching and so moving. I'm 69 years old, almost 70, but I had unusual interests in hospice and aging, and a student membership in the National Hospice Organization was $25, and that was and I earned $1.50 an hour babysitting for Monica Helwig's kids. So it took a long time to save up for the book, but and the hospice movement and to pay my dues. But thank you. This was thought provoking and moving. And I hope I'm being articulate, and maybe there are others who can chime in. But with what's happening in this Trump administration, and with the brain drain from NIH, from every facet now with this new virus, and there aren't folks at the Food and Drug Administration anywhere as CDC. It's all been gutted, and there's no regard for ethics, for morality. I'm not articulating, but I think you know where I'm going. Do you have any pearls of wisdom using our mercy and Jesuit Ignatian values? I mean, I don't even know where to turn. I watch the news, and right now there's no one. They just several. The former Secretary of HHS, Kathleen Sebelius, was on the news this morning. I mean, there's no one. There's no grown up in the room. There's no one. Um,
No, I totally understand what you're saying. Now, I
I
don't
hope
know
I'm
that
not
I have.
offending anyone else on the call. I'm sorry.
Yeah, well, I don't. The problem is, let me just say objectively, there is within the United States, and I don't want to say that it is simply this administration, there are strains of what I would call deep anti intellectualism in the United States, a mistrust of the intellectual life, and a mistrust of science.
Science.
And my own education taught, and I believe Catholic philosophy supports, that what we seek is truth. And so the scientific methodology, the science is clear, and we need to use that scientific reality, whatever the reality is, as the reality from which we teach or argue. As so, do I have any hope? I mean, I'm as concerned or afraid as you with this new virus, although please God, it's not as bad as COVID. Um, I'm even more concerned about what happens to the poor, because many, prior to, I hate the term Obamacare, the Affordable Care Act, prior to that, the United States had over 40 million people uninsured. That changed a great deal. I think we got down to about 12 or 13. And it was not that those 12 or 13 million could have had the Obamacare, they could have had the Affordable Care Act services, but they chose not to because they were almost libertarians, I would say. Now, so so there's a philosophy that is not simply with the actions of this administration that needs to be looked at. One of the signs of hope that I have had recently is some of the statements of Pope Leo, but also of some of the American bishops with regard to war, with regard to, there was just a recent thing that came out about care of mental health. So I think I'm experiencing some leadership within the church that is a sign of hope to me. And the other thing that I have to keep hoping and working to try to instruct persons who work in healthcare to say, basically, the very basic fundamental good within Catholic social teaching is the human dignity of each person. And so that's where we have to begin with, certainly with migrants, with people that are mentally ill, with people that are drug addicts. What it is about is God's spirit living in that person. So that doesn't satisfy. I mean, it's not solving the problem, And the other thing that I do when I sometimes when I would have an ethics case that was really difficult. I remember coming out of one, and there was with some doctors and nurses, and we met with the family, and it was really a difficult case. And I did not want us to force the daughter of this dying woman into a decision. And so I said to her, as you can see, your mother is close to death. We are going to need an answer from you, but I can sense that you are really struggling. I invite you to go home, talk to your husband, talk to your minister, but we need you to get back to us by 9 o'clock tomorrow morning. And then after she and her husband left, I said to the other doctors, I tell you, I am going to chapel right now and pray like mad for this poor woman. And I really believe in the power of that prayer. And ironically, 9 o'clock the next morning, she came in and she said, she called the doc and she said, and it was something simple. She was willing to make her mother a no code. I think that's what it was. But I think prayer, we need to bring as much prayer as possible to the reality that we're facing today. Anybody else? And it does not have to be a question. It can be a comment. Anna?
Pat, I'm happy to jump in. It's lovely to see you, and I thoroughly enjoyed your presentation. I think it was almost an ethnographic overview, really, of medical ethics, and so thank you for that. And I don't know whether it's a question or whether it's a concern I have going forward. I think your emphasis on being able to pray for the patients and that real strength that comes from that mercy tradition and from our Christian tradition. And I guess my concern for the future is that as we get increasing numbers of non-religious people and people who don't hold that faith tradition, how do we safeguard uh, that power of prayer, the importance of spirituality, and how that then influences like the wonderful ethics that actually comes out of our tradition. So I don't know whether it's a question or a comment or whether it's whatever, but look, anyway, needless to say, that's where I'm thinking, and thank you so much for your presentation.
Anna, thank you. It's a great point that you bring up. And I would say to you, I do not fear persons of other different faiths, and I'll give you some examples of that but what I fear are people who are anti-religious, people who are filled with so much I don't even want to, it's not hatred, it's more despair. So I don't know even how to describe it, but who are filled with that notion and who cannot recognize, I use the term human dignity. Many other writers, it's within the Catholic tradition and Protestant, for example, I'm thinking of Karl Barth, who talked about the sacredness of human life. And he was writing this in the midst of what was going on in Germany, before World War II. So I think there are ways of being with patients or families of different faiths and helping them to recognize or even trying to elicit from them how do they perceive the sacredness of that life. I will have to say to you that I don't know. I worked a lot with people in labor and delivery and neonatal, and they were definitely not all Christian, but there was such a strong sense of the sacredness of life and the power of life within those children, within those families. And I think I know one of the chaplains that I worked with, who was a wonderful priest, he wouldn't he would just say to them, can we have a moment of quiet? And I want you to think about whoever it is, your mother, your child, and what's the meaning of that person's life to you, so that it's not forcing it on them. But I agree with you, and I think there are certain areas in reproductive technology where standing strongly for the Catholic teaching can bring us derision. And I think we need to do that. We need to continue to speak out, and I have some hope, I think, because of some of what has come from the synod. So that's enough for me to say on that one.
No, I completely agree. And I think, yeah, I think that that question really what you're saying that there is that non-religious element,
Mm-hmm.
but I guess it's the important bit for me is that framework that we can continue to draw on, which actually gives strength to our Catholic community
Right.
or our Catholic hospitals because there's that commonality in terms
Right.
of what it is. And I think the danger as we get increasingly large non-religious and different religious traditions is that to find that common sense and the human values that come through. So anyway,
Right.
thanks,
Good. Thank
Pat.
you. Vicky, wait a minute. Yeah, unmute yourself. No, Vicky,
Got it.
okay, good.
Okay.
There you are.
I just want to tell you about my first hospital board meeting because I think it ties into what you two were just talking about. I had just finished, Pat knows I have a degree in canon law, so I had finished that. And I went to a meeting where the merger was between County Hospital and Mercy Hospital. I thought there was a misprint when I read that Mercy was bringing 17% of the assets. 83% belong to county. So first of all, they're saying, well, canonically, what do we have to do? And I said, okay, I've got 12 points that we have to at least discuss how it's going. And the priest who was representing the bishop said the bishop has 10 of those, and I think he wants the other two. But then I said, I just have a serious question. I said, it's my very first hospital board meeting. Maybe it's my own stupidity. But how come we're bringing 17% of the assets and we're naming 50% of the joint board? And the people who were leading the meeting looked at the county administrator and he said, you're not from here. This is a very rural area. If my wife got extremely ill right now, her choice would be to go to Mercy. Mm-hmm. And he said, so you're naming 50% of the board so that we will have the trust of people trying to do the best thing for everyone. Mm-hmm. We'll have the trust that not Catholicism is going to be shoved at them, but whatever their beliefs are going to be respected by the doctors and the nurses and will continue to be respected when they can't respond anymore. And that was such a moving moment for me, way beyond any medical ethics that I learned in serving on a hospital board. We really take for granted that mercy background that we have in hospitals or healthcare. To other places, that's an absolute gift. And we have to not be backward about claiming it.
You're absolutely right, Vicki. And it's those elements that you mentioned, but it's also if the Catholic facility is well managed or Catholic system is well managed, it's bringing that management and services to that rural community. Mm-hmm. And it's also hopefully bringing the excellent nursing tradition. And I'm watching my time, I know, but there was a Catholic hospital I worked for in the Midwest that was rural and but a very tight knit and well, probably there were Catholics in the town, but it was also very German and very Lutheran. And they, at the time that they were seeking to join the Mercy system in St. Louis, the Mercies named a sister, a particular sister who was also a nurse, as the administrator. And she came in, and I mean, this was a rural hospital. There were two brothers, docs, who were surgeons who really had pretty much performed every surgery in the whole town. And one of the first day, I forget what day. They would. I forget what days of the week they did do surgery, but on Wednesday they would stop at noon, and sometimes they would go play golf. But because this was such a rural area, a lot of times they would go hunting. Okay, so this doctor, she's so somebody calls her and says, "Sister, I think there's something a little bit um out of different going on here." And she goes up to the OR. Now, the doors are locked, and everything has to be surgically clean and disinfected. And she looks in the glass window to the OR, and there's the surgeon's hunting dog under the table. So she waits, and then says, he comes out, and he's going to have somebody's going to help him off with his scrubs, and he's going to wash up. And of course, he's waiting to get the heck out with his gun and the dog to go hunting. And she said to him, as soon as you get cleaned up, I will see you. And she ripped into him. And of course, he was furious. Like, why do we ever sell to these people, and who do they think we are? But I remember going back to the town and talking to the man who was head of the local newspaper. And he said, when the Sisters of Mercy came in here, we weren't prepared for the fact that they were going to really challenge us, but they have given us an excellent hospital. Mm-hmm. And so it's not just about the money. There's other things are of value. Anybody else? Yes. Miriam, Teresa, and again, thank you. Just unmute yourself, please.
I'd just like to refer to the slide that had logos from various entities.
I probably missed one.
No, you had Northern Light Mercy, and it's Portland, Maine, not Portland, Oregon.
Oh, God, I'm sorry. Did I say Oregon? Well, I knew.
It's an example of a Catholic Mercy hospital join a not Catholic hospital sort of system in the state of Maine that is working very, very well.
It is. And actually, several years ago, I went and gave, I don't know what, some kind of the board was having a retreat, and I went up and worked with them, and I've been to that hospital. So I knew in my head that it was Portland, Maine, but God knows how the Portland, Oregon came out.
Okay.
Thanks.
Thank you. Yeah.
Okay, I don't want to necessarily keep you longer than we need to, but I would just say to you to continue. Again, going back to that slide with the real impact that Mercy has had on healthcare in the United States. I was trying not to overkill on slides, but I have two slides that I just love and show sometimes. One is an early painting of the Crimean War when Florence Nightingale is in the painting, but there's a Sister of Mercy there. And then the other painting that I love is the painting that's in the Smithsonian of the sister during the Civil War caring for the soldiers. And as those of you that know our Mercy tradition, the Sisters of Mercy cared for persons who were injured, who were both either North or South. It didn't matter who they fought for. It was what was the need. And so I would just encourage the people here to continue to pray for and support and encourage those people that are involved in Catholic healthcare. And if you know any young person who is really interested in this and would love to become, would be interested in healthcare ethics, even don't hesitate to send them to talk to me. I will say to you that at a recent gathering, now I'm not able to travel as the way I used to, but I get discouraged because there are fewer women choosing this field, and I'm not sure why, but I would like to try to rectify that. So, Shelby, I think that, well, it brings us, I mean, I think I'm going to 5 minutes. We have 5 minutes leeway, but we don't have to fill up that time.
Perfect. Yeah. If no one else has any other questions, then I will wrap us up very quickly. So, once again, thank you to Sister Pat for taking the time this afternoon to share with us what she presented today. And like I said, if anyone wants to view this after, I know we had a few latecomers. I will be posting this to our social channels, including our YouTube channel. You can find us at Mercy Archives on any of our socials. So thank you again, and I hope to see everyone at our next one on July 8th. So y'all have a good rest of your day, and thanks again for joining.
Thank you so much. So timely. Thank you.
Thank
What
you.
a gift. Thank you.
Okay.